Hello, this is Dr. Rockhold. Welcome to the first of three segments on opioid analgesics. Opioids are remarkably efficacious painkillers. Unfortunately, in overdoses, they are also people killers. So knowing how, when, and to whom to prescribe opioids properly is a big deal. Most of you will recognize that we are currently in an epidemic of overuse and overdoses of opioids. The slide you see here is a Clarion Ledger headline from 2016, the opioid epidemic that happened before the current COVID-19 epidemic. But not only did it start before COVID, but it is still with us. And in fact, it is currently more deadly than COVID. To give you a comparison, as of October 15th, 2021, 722,000 persons are known to have died of COVID-19. Compare that to the period between 1999 and 2020, when over 841,000 persons died of an opioid overdose. Over 100,000 more dying of opioids than have died from COVID-19. And in the most recent year, 93,331 persons died of an opioid overdose. The medical center here has constituted an opioid task force, and part of the function of that task force is to improve education about best practices in opioid use to reduce overdose problems. Hopefully these lectures will help you achieve that goal. So let's begin by defining what opioids are. I'm going to introduce three terms: opioids, opiates, and endogenous opioids. Opiates technically refers to any alkaloid drug extracted from or derived from opium, or are produced synthetically to bind specifically to opioid receptors. In properties that they exhibit include the ability to block pain, induce sedation, depress respiration, and produce calmness or euphoria. Opiate use is also associated with physiological tolerance, physical and psychological dependence, and addiction upon repeated or prolonged use. Opioids is a general term. It encompasses not only the natural and synthetic compounds we've just noted, but it also includes three well-known groups of endogenous opioid receptor peptides, which act as agonists at specific opiate receptors. The enkephalins, the endorphins, and the dynorphins are those three groups. There is, in fact, a fourth group, the endomorphins, that is also encompassed within the term endogenous opioid peptides. We can also define opioids not only by their origin, botanical or semi-synthetic or synthetic, by their classical analgesic actions, which we've just mentioned, and as agents that stereospecifically bind to one or more of the opioid G-coupled transmembrane receptors, and or whose binding can be competitively antagonized by the opioid antagonist naloxone, known in the trade as Narcan. At this point, I think it's useful to look more closely at the natural source of opiates, which is opium, and some of the relevant chemistry of key opiates. Opium is in fact the rosin, which is obtained from the opium poppy. It is obtained by scoring the side of a ripe opium poppy seed pod. What occurs then is a white gummy latex exudes from those cuts. When this resin is collected and dried, it becomes a brown gummy substance, and that is raw opium. Raw opium contains not only the natural pharmacologically active morphine, which is present in about 4 to 21% by weight, but also codeine, which is present about 0.8 to 2.5% in raw opium. There is a third compound, thebaine, which is also found in raw opium. Thebaine does not have opiate properties, but it is a very important source from which semi-synthetic opioids are produced. There are 3 specific compounds pictured here that we want to talk about. First, you see the structure of the prototypic opiate, which is morphine, and codeine and heroin. Codeine is monomethyl morphine, and it is converted by demethylation to morphine in the human body and thereby exerts its effects. Heroin, on the other hand, is produced semi-synthetically as diacetyl morphine. It is much more lipid-soluble than is morphine, and hence gains much more rapid access to the high lipid environment of the brain than does morphine. When in the brain, heroin is deacetylated to morphine, which becomes the active compound. You should be able to recognize that there are multiple opioid receptors that are involved in the action of these compounds. We currently recognize 3 major G-protein coupled transmembrane opioid receptors. These are the mu, the kappa, and the delta opioid receptor. Clinically, virtually all of the relevant effects of opiate drugs are mediated through the mu opioid receptor, as is noted in this slide. There's one exception, and that is the fact that activation of the kappa opioid receptor by an opioid can cause a characteristic malaise, a dysphoria in some persons, and we'll speak more to that in later lectures. There's also a 4th receptor system called the nociceptin or orphanin FQ system that's worthy of mention. Nociceptin, the other name for which is orphanin FQ, is a 17 amino acid peptide, and it's structurally related to the opioid peptide dynorphin A. However, it does not bind to any of these 3 mu, kappa, or delta opioid receptors. In fact, it has a unique nociceptin opioid receptor, which is abbreviated as NOP. Looking at endogenous opioid peptides as endogenous ligands for these receptors, their specificity is that endomorphins are the most potent agonists for the mu opioid receptor that currently exist. The endorphins are also mu opioid receptor agonists, while the enkephalins act as agonists at both mu and delta opioid receptors, and the dynorphins act as agonists at the kappa opioid receptor. We will look at 4 therapeutic categories of opioid drugs. First of these are the strong agonists, typified by morphine. These are agents that have full agonist activity at opioid receptors, particularly the mu opioid receptor. In contrast, the mild or moderate agonists are typically only partial agonists at these receptors, and codeine is a good example of this group. Mixed agonist antagonists, these are agents like buprenorphine that are interesting pharmacologically in that they may have agonist activity at 1 or more of the 3 primary opioid receptors while acting only as partial agonists or perhaps antagonists at another of the opioid receptors. And finally, we'll look at the narcotic antagonists, and these are agents, as the name suggests that block the action of opioids at the receptors, and the prototype agent here is naloxone. The major pharmacodynamic effects of the opioids are presented on this slide. Within the central nervous system, the analgesic, euphoric, and sedative effects of opioids are primarily mediated by the mu-opioid receptor, as we've discussed, and they are dose-related. They also can produce a characteristic respiratory depression. They reduce hypocapnic drive in the central nervous system particularly, and this can result in lethality. They suppress cough by inhibiting the medullary cough center. Codeine, in fact, is effective as an antitussive in doses that are not sufficient to produce analgesia. Opioids characteristically do not cause seizures, but they do occasionally increase muscle tone in the thorax and can cause some truncal rigidity that can further reduce ventilation. Nausea and vomiting are caused by stimulation of the medullary chemoreceptor trigger zone, and meiosis is due to stimulation of the parasympathetic tone from the Edinger-Westphal oculomotor nucleus. This meiosis is characteristic of opioid action and is one of two opioid actions to which tolerance does not commonly occur. Inhibitory actions on the gastrointestinal tract should be expected and can be severe. You should assume that constipation will be a problem whenever opioids are administered and for the duration of opioid therapy, as constipation is the second of these actions to which tolerance does not occur to any significant degree. Urinary retention, biliary spasm are other GI-related effects that can be noted with these agents. Direct effects of the opioids on the circulatory function are not usually significant. However, many opioids, in particular morphine, can cause histamine release, and this has the potential to lower blood pressure and is the cause of the itching and pruritus that often accompanies administration of at least some of these compounds. There are effects on neuroendocrine function, particularly an inhibitory effect on ACTH release, as well as on release of gonadotropin-releasing hormone and luteinizing hormone. Opioids are known, in contrast, to stimulate release of prolactin from the pituitary gland. Given these several effects that opioids can produce, what do we use them for clinically? Well, as we might suggest, analgesia, pain relief, is arguably the primary indication for the use of an opioid. Using them for cough suppression is frequent, and inhibition of bowel function can be very useful in the relief of diarrhea in at least some patients. We use opioids frequently to provide pain relief during anesthetic requiring procedures. And we also use opioids in a variety of ways to help us manage patients in whom opioid use disorder is the primary diagnosis. And we'll discuss these agents in greater detail later in the lectures. Opioids are specifically contraindicated in a number of circumstances. The first of these is the combination of a pure agonist with an agonist-antagonist compound. So in this situation, giving the agonist-antagonist agent, for example, buprenorphine, to a patient who has been receiving a pure agonist like morphine is likely to block the action of the full agonist and precipitate withdrawal, something you'd like to avoid in your patient. The opioids have the tendency to increase intracranial pressure and so are generally contraindicated in head trauma because they may mask symptoms of encephalopathy and or further increase intracerebral pressure following a head injury. In labor, they can suppress fetal respiration and in situations where the mother has been using an opioid during gestation, they can lead to dependence in the fetus and offspring and withdrawal in the child following delivery. They should be avoided generally in patients who already have impairments in pulmonary function because they will further depress ventilatory function. Examples of relative contraindications would be patients with emphysema, kyphoscoliosis, severe obesity, and cor pulmonale. If your patient has impaired kidney or liver function, it's important to recognize the metabolic route for degradation or elimination to ensure that the impairment in function does not adversely change plasma concentrations and clearance of your compounds. They have to be used in care in patients who have adrenal insufficiency or hypothyroidism. In adrenal insufficiency, opioids can further suppress adrenal androgen and cortisol production. In hypothyroidism, a number of the effects of the opioids tend to be exaggerated, and this can lead to toxicities. This is the end of the first of 3 sections on the opioid analgesics. I'll see you back in the second set.